right, what are we going to do in this session? This is an open forum. You get to say what you want, ask us questions, bitch, piss, moan, whatever you want, because there are two divisions of healthcare. There is a semi-science, which we all read about, look at, process in the journals every month. We come and talk at these meetings. The second part of it is you have to deliver care. You actually have to treat people. And we're much better at publishing papers than we are at actually running hospitals and emergency departments. So we want to know what you're doing, what you've done, how you've made it better. And we're willing to listen. You got to remember, this panel up here, you're looking at three of the most dysfunctional people from one of the most dysfunctional.
I'm a very functional person.
Yeah, he's not a bad person.
He doesn't know.
These two.
So we're happy to hear any ideas you have. The other thing is we understand
I'm just happy to have
one
company.
model doesn't fit all. One thing doesn't fit all, and what you do at a 22,000 visit department in Pavugnatuck has nothing to do with inner city hospitals. So we'll listen to, and what you do in Australia and what we do here may be quite different. So here we go. Billy, you want to start out?
I got a good one, and I couldn't agree more with this person. They point out that one of the things that can improve flow is finally winning the argument with your radiologist that for most belly CTs, you don't need to give contrast. And so we have, over the years in this course, reviewed, now the stack is, I don't know whether it's 12 papers or 15 papers or something like that, that if you're looking for API or traditional problems, you don't need to be giving oral contrast. And that oral contrast, I'm always amazed by that. The oral contrast, supposedly the patients rule out API or something like that, so they're NPO, but first you have to drink 3 quarts of this, then you have to wait an hour, drink another quart, then you got to wait an hour with the idea that somehow this contrast and this person who's got like no bowel sounds is going to percolate through to the end of their GI tract so you can image up their appendix. The literature on it is pretty unambiguous that you don't need to be doing oral contrast for all but a few exceptions, and we can talk about that in a second, and that will definitely increase throughput, because nowadays if you have to give contrast, if you have to give the contrast, that's a minimum 6-hour visit. And so this will change your belly pain workups on those where you decide to go to CT. Sort of as a related thing, I would also add, and doing more and more ultrasounds and fewer CTs for whatever indications you can is the other way of beating back this. And when we talk about this in these settings, a lot of times what we hear, how many people are still giving oral contrast in their EDs here? So what happens in those places is when you talk to them and say, why can't you get this changed? They say, well, our radiologists say we're not the academic radiologists who are publishing these papers, and we feel more comfortable with CT, with contrast. And so they're unwilling to get off the dime. There's now enough papers, though, that you can put a full package there and say we got to stop doing it, and that it's not even an issue of the images, it's an issue of the ED overcrowding that's a result.
And by the way, it's not emergency medicine literature we're quoting here. It's radiology literature. Took it in, put it on the table, and said, here's our 12 papers. They said, yeah, so? Those are a bunch of pinheads from Yale and stuff like that. We don't want to hear them. We're in Pavugnatuck. We think this way to go. They can't produce a paper that says it's better. It just doesn't exist. And as far as I'm concerned, did you ever taste that stuff? I've tucked my finger in, tasted it. Now you're sick. Now you're nauseated. Now you've got appendicitis, and I don't think they really need anything. If you're a 16-year-old boy with positive findings, just take the appendix out. But the bottom line is nobody likes drinking the crap. You're sitting there. Now it's 2 hours into it. Just get rid of this. It's just crazy stuff.
So there are a few exceptions, and we actually now have a policy at USC that's no oral contrast across the board, unless you're looking for something like Crohn's disease, where you'd like the dye to go into a fistulous tract, or you're looking for an enterocutaneous fistula. Things like that, they still will request them. But for the vast majority of, you haven't had an operation before, you got belly pain, it's bad enough, we want to find out what it is, it's CT. But we're taking out more and more ultrasounds.
Yeah, that's not a 4-hour prep either. I mean, as you pointed out, if you're going to get it all the way down there, it's going to take time.
But I think that, I mean, we had a pretty robust discussion on this. I can't remember if it was on
Yesterday.
day 1 or day 2 already, like on some of these abstracts and papers and things. But a point that, Greg just made, which I think is a really important one, which is that, even if you're saying, okay, we're not those fancy academic docs where they have like, these attendings and things like that. It's not like at USC we've been not using oral contrast for decades either. This is a relatively recent change there that required quite a bit of fighting, and so this is a difficult one to change, but it is something that's worth it to change, and it's probably one of the best things we can do to improve our personal sort of efficiency within the emergency department for these abdominal pain
Comment
patients.
over there.
Comment.
How do you get the list of these 12 articles?
You just email Billy.
Yeah.
I'm happy. I'm actually happy to do it, but
Yeah.
they're all in the EMA database. I mean, there's more than it's obviously the EMA database is by no means a 100% complete database, but it's something that Rick has been interested in gathering, and so there's a beautiful collection of them in the EMA database that can be searched in about. I mean, I might be able to do it at the next break for you.
Yeah,
out there on one of the computers.
in the packet where we talked about that, I can't remember if it was editor's choice or
It's editor's
it was
choice,
in
yeah.
editor's choice. If you look at that particular article, it also references a lot of the other recent articles. If you just sort of look at, they're like in the discussion section, they have references to 5 or 6 more, so then leads you to 5 or 6 more. I think just based on even that one, you can get all the evidence you need, and that was not published in Emergency Medicine Journal.
What was
as
very
pointed
interesting
out
in
on
several of the
panel.
articles, they looked at kids and then asked this question. When they actually took the films, how often was it that the dye had actually made it to the
Yeah,
appendix?
that's the abstract we talked about earlier.
exactly. And it's just, it's ridiculous number.
I mean, one of the, back when we were doing it, you come in at 7 o'clock and there was a sign of sort of, and trust me, I know how hard it is to work nights. I still work them, but the intellectual surrender of the night doc when pass-ons are, this one's waiting for an abdomen CT contrast with pelvic, this one's waiting for an abdomen pelvis with contrast, this one's waiting. It's like the pass-on from hell, which is, you're going to take over the shift in the morning waiting for 5 CTs to be done and read. It's like, boy, I was hoping I would have a coffee and let the ER warm up in a normal way, and now I got all these nightmares.
Next.
Next, so this is an innovation that somebody said, and they call it the doc on call. I don't know how I feel about this, to be honest. So it says schedule based on known high volume periods where one doc is on call, but during known, quote, busy hours, they have a second doc on backup call.
This is a flexible scheduling issue.
It's a flexible scheduling issue, and it's we know we're going to be busy. It's Friday night. There's good. It sounds like they're saying good potential that it's going to sort of overwhelm our current staffing and resources.
I just wanted to see what they
Well, I don't
wrote.
care what you want to say.
Yeah.
Listen like everybody else.
It's an innovation. I want to know if it worked or not.
So
I'm gonna ask
say
that
whether or
part-
not it works.
So they-
Someone's got to fess
Someone's
up.
got to raise their hand.
So there are
and tell
lots
us
of
whether it
places
worked
where
or
this
not.
has been done. Rick Picotta did it at San Gabriel for years, where once the waiting list got up to 10, 12, whatever you call second doc in, the implication is that the main thing holding up the flow is a physician, which may or may not be true.
Well,
what's
it's
often
not-
been found is that it's pointless to call in another doc if you don't call in another nurse.
By the way, how many of you had a situation where the hospital required you to call in a doc if there was a certain waiting period? Hands? Anybody have that in their contract?
Oh, no.
When we looked at that, I said, I'll be happy to sign that as long as you sign, when I call in the doc, you've called in a tech, a nurse, a transporter, because when you really do analysis of the backup, it's rare that it's a doctor shortage. What good does it do to have one more doctor giving orders to the same number of nurses who can't get the job done now? It's just, you know what this is? This is the hospital administration making himself feel better and not asking this question, what's the team we need to get the job done?
Again, it's the basis of this. We're going to talk about ED overcrowding at the end of this and look at Peter Vicello's chapter. The root cause of this schedule, where you have a doc on call, is a belief in something that has been pretty well shown to be false. And that something is that the cause of overcrowding is minor patients at the front door.
No.
That's not the cause of ED overcrowding. The cause of ED overcrowding is sick patients in the ED who you can't get admitted. And so we're actually going to look at a paper that shows exactly that. So this front door myth is what generates this. Now, if there were a bunch of, meet, treat, and streets waiting, then calling in another doc who could meet, treat, and street. In other words, a whole bunch of people who didn't need orders, didn't need things done, didn't need to be bedded, didn't need tons of stuff, maybe just an x-ray. If there was that, then having a doc, they could come and clean those up in an hour and a half or 2 hours, and that would work. But if it's about complex patients where they need a line, they need meds, then it's pointless to call in a doc without calling in a nurse or a tech or other support.
Yes, please.
And how many mid-levels are here? I know they asked earlier. So there's, another way that they do this is they beat up on the mid-levels. They schedule mid-levels to come in, but it's the same issue. They're going to write orders and do things the same way, and they're going to need the same support, the same transporters, the same, but a lot of times they'll do that. They'll have a second mid-level. It's a way to cover, or they do the backup doc. But I think it's based in a fixed false belief that minor patients at the front door is the problem. And it's also based in a fixed false belief that another doc, unless they're going to start their own IVs, do all their orders, and push their patients around, they need, the way our hospitals work, any person coming in to write orders is going to need support staff.
Yep.
Even another clerk would be nice.
There's a comment in the third row there.
In Australia, one of our KPIs is time to be seen.
Right.
So it keeps admin happy because they're all being seen in the right time frame.
KPI being
Yeah.
key performance. Got it.
Yep.
It's key.
They've got to tick in the box because they've been seen.
Yeah.
Help the patient, really, other than they may get their analgesia or antibiotics earlier if they're waiting when it's crowded. But
By the way, I've spoken in a lot of countries. This access block question is the same everywhere. There's a hospital in Massachusetts that hired me to try and solve a problem. I went. It's a 52-bed emergency department. Unfortunately, 29 of the beds, when I started at 7 in the morning to look at the question, were full of psych patients, some of whom had been there for 2 days. You know what they had functionally was a
If they weren't a
20-bed
danger to others when they arrived,
They are now.
after 2 days in the emergency room, I mean, they were just a danger to self when they arrived. But after 2 days, they're also a danger to others.
Well, Billy's the example. Would you like to see him after 2 days? I mean, no.
That's why we limit him to 2 in this conference.
I actually get along with them fine. I understand them perfectly.
Yeah. Well, I think this flexible scheduling thing is very complicated. I agree that overall this is probably not a physician thing. That said, we have to be part of the solution for this. And I think that Greg's point is really the one that I want to emphasize. That is, if people are demanding this, I have no problem with that. I think, paradoxically, I don't think it should be the PAs and the NPs that are the ones that are on call, but it should be the department chair and the medical directors and people like that who are frequently have administrative duties anyway, and they can take that call while they're doing administrative duties if you want. But that has to be tied to a more robust plan. At LAC USC, we've had the surge plan for times of severe overcrowding, which is approximately 97% of the time. But during that surge plan, it does activate the entire hospital. So we have things we have to do with our staffing and everything like that, but the hospital administrators have to be made aware. They need to be alerted to the crowding situation, et cetera. And I think that's really the key here, is that in isolation, adding another doc is pretty unlikely to help, although it might allow you to increase your bottom line so that you don't miss those people who are going to take off without being seen who had minor complaints. So you might be able to catch those anyway.
Which is just lost money. And
just
the people who left without being seen who had more serious problems, because every study that looks at this says the LWATs aren't just the bullshit that could have been seen.
Yeah,
among
sick.
the LWATs is about 10% of them who were too sick to wait.
Exactly. Yeah. Comment.
I'm just going to say, not all providers are the same. Obviously, we have guys that see 3 or 4 patients an hour, and others see 1 or 2 patients
Sure.
an hour. If you got too many of the low productivity guys, you got big trouble. You could use another provider.
You're talking about the American tourister.
Yeah.
When you show up for a shift and the person working alongside you is a hard-sided piece of luggage that you'll be carrying for the rest of that shift.
Right. Yes.
Also sometimes referred to as the partnership longboard.
Yeah.
You're the young guy who's not on the partner track, and when you come in, it's 4 hours before the end of the partner shift, but they're hanging 10 on a longboard and cruising out the rest of that shift.
Yeah.
Ordering a bunch of CTs, abdomen, pelvis, which they'll pass on as evidence of their intellectual surrender to the next doc.
By the way, I make a little statement that we publish papers, thousands of papers every year in emergency medicine. When is the last time you saw a paper that talked about variability in staffing? I'll just state this. I think we need half as many nurses, twice as many techs, more PAs, less docs. If you're going to join this century, we're not doing it correctly, and nobody's publishing those papers. And do you know why? They don't want to know the answer when you ask that question, because most of what a doc does doesn't require a very good or smart one. It's getting it done, and we're not asking the right set of questions. I'm just telling you.
All right, I'm going to talk a little bit, since there was a rumble in the room when the mention of psych beds occurred. So this is a multi-part piece. I'm only going to read the first one right now. It said the innovation at this particular place was psych beds off the ED, as many of the patients stay up to a week, and they only have 25 beds. So, and I think, Sanjay, you had something
a couple
about
in
psych.
my section too.
So psych problems are a massive issue in emergency medicine, right? So they functionally decrease the size of your emergency department significantly more than a normal non-psychiatric patient, because they tend to stay a long time. They occupy, there's frequently some nursing issue, or
and they need a sitter.
They need a sitter. They're one-to-one. All these kinds of things. Not to mention that they're at high risk for decompensation. Unlike most of our patients who are not, they actually get better by being treated in the emergency department with fluids and antibiotics and stuff. The psychiatric patient typically goes from mildly agitated and crazy to progressively more thinking that you're the devil, to the point where they're finally getting taken down, and then they get injured and everything else happens. So the question is, what do we do about, how do we maintain the capacity of our EDs when psych facilities are closing, the patients are showing up in our EDs and taking away our beds? This is a major problem. So I don't know.
Big focus for Cal ASAP this year is trying to obtain more funding from psych and more psych support. Here in California, we had the Steinberg bill, which was the millionaire's tax. But the millionaire's tax, the money from it could only be used for outpatient psychiatric care. Now, even though emergency departments do a lot of outpatient psychiatric care, we were denied access to that money because we're hospital-based physicians and care sources. So they didn't want the facility fees. It's only for outpatient psych. And while that bill was useful, it didn't result in a bunch of building of new outpatient psychiatric centers or resources for inpatient locked beds, which are the big problem.
I was in Germany last month, and the Germans have a certain way of doing business, as we pointed out this morning. They're very neat, very clean, absolutely humorless, and okay. And people like it. You will like what you say, yeah. But
I don't know. She doesn't seem that funny to me.
Yeah, it doesn't seem that funny.
Tell us a joke.
Tell us a joke. All right.
We'll decide.
In any event, the Germans went on record as saying, if all understand how drug abuse and psychiatric illness all sort of overlap. Well, the Germans have had it, and they've said if you've been in 3 times in a treatment mode, you're not getting in again, because the success of yes, exactly right. The success of this is going nowhere, and they just said, sorry, kick them out of the ERs, because in Germany you can look up everybody's record in the country. Their computer system is pretty good, and they can kind of figure it out. But I would tell one story. I was giving a talk to young Germans one time. And at the end of the talk, my host, Hans, came up and said, Dr. Henry, we'd like to take you for a night of German fun. Well, that didn't seem right to me, okay? And so I said, what do we do, get drunk and invade Poland? And see, I thought that was funny, okay?
Yeah. And they're constitutionally sensitive about that particular issue.
Yes,
I think if they laugh, they can be arrested.
No, the great line.
And I'm not kidding.
The great comeback.
Is that true?
No, yeah, you can't.
I think it is true.
That's right. You can't sing Uber alles anymore. I promise you that. Anyway, what he said then was, Dr. Henry, he said, we do not do that anymore.
I did have a question about this for the audience, about this behavioral and psychiatric patient. So where are you experiencing the delay? How many of you have a ready access to someone who can perform a psych evaluation? That's not the problem. So, but for half of you, you don't.
So,
Is on the-
Placement's the problem. Placement's
Sure.
the problem.
yeah, that's right.
right.
Yeah, they got the alcohol
So
has to be
medical
under 100.
clearance.
Then they're withdrawing and they're no longer medically cleared.
Right, exactly.
And then the other question I have, this is of academic interest to me, is this for the suicidal patient or is this for the agitated, crazy person patient?
All the above.
No, but what's driving it? I mean, are 90% of your cases that are like that, are they the suicidal case or the non-suicidal case? Suicidal? No. Yeah. No, I'm just curious because.
How about adolescent psych? That's the hardest one.
Yeah.
Adolescent psych, there's so few adolescent psych beds that, you could, here in Los Angeles, finding an adolescent psych bed could involve a fixed wing transport to one of the states made with a ruler.
Yeah.
Because that's the only place there'll be a bed. Yeah, because our holds last.
Yeah,
So
congratulate
by law in
yourself and let 'em go.
California, you can hold someone without a psych eval for 8 hours. Then they have to have a psych eval. They place a 5150, which is a 3-day hold, and that hold can even expire. Right, so we have, depending on where you work, we have,
Depending on
they
where you are.
call them different things, the POW team, Psych on Wheels,
Pet
or
team.
PET team, Psych Emergency Treatment, or Psych Eval team, POW, PET, there's all kinds of, little names.
Yeah, a
for it.
lot of the smaller hospitals don't have access to a psychiatrist, so they call in these pet teams, and then they put people on a pet.
Has
It's kind of
anybody
weird.
ever seen a psychiatrist in the emergency department? I saw one once when he cut his hand. And I don't know what I'd ask him to do because we've made a decision. We just need to get them gone. They need to disappear. And that is a huge problem around the country, and I don't see it getting a lot better.
So
One thing that happened was we did put on what I consider the most valuable person in the department, if you want to be efficient, a social worker who was actually useful, who could get placement for old people to homes, psych people to beds, and could make the place move. That's the most valuable person
We went to
ever
24/7 social work at our ED, and it made a big difference.
added. Huge.
We have a nurse at our hospital who's there from during the daytime to PM shift. We just have an issue at nighttime at our hospital. We have to decide what happens. And it's usually an issue with our frequent flyers. And then as we get with the mobile unit, who doesn't come until like 1 o'clock in the afternoon.
Of course it's at night. Psychiatric disease grows in the dark, right? We aren't even allowed to give this course at night with Billy because of what happens. Psychiatric disease grows in the dark. And I don't know when they're going to realize that we're a 24/7 business. And you realize the rest of the hospital is not a 24/7 business, and they don't recognize what we do. They just don't.
The other day I was in the ED, and we had a psych patient who Houdini'd. And so they got out of their restraints, and the sitter was there, and the patient's like going down with the thing open and the butt flashing down the hallway. And so people looked at the sitter and said, what's going on here? And she said, I notified you. She goes, well, why didn't you do something about it? And she looked at her deadpan and said, the title of the job is sitter.
It's not chaser.
It's not tackler. It's not chaser. It's not tight end. The
Yeah.
title of the job is sitter.
Yeah.
It's funny that we talk a lot about EMTALA being this federal mandate to care for people, and we rarely talk about the imposition that a 5150 and 5150 laws across the nation impose on us, because they really are laws that allow people to say I'm suicidal, which, by the way, all available data suggests that a person who comes to the ED saying they're suicidal has a lower suicide risk than the general ED population. So being on a 5150 is actually somehow protective against suicide, which is a stunning sort of fact, but it's true. So it doesn't do anything, but it does. It basically opens our doors for people who are at their wits' end without compensation associated with it. And moreover, it allows them to then shut down outpatient facilities and say, well, we've given, people have a refuge, which is in the emergency department. And I think that we should be much more outraged about these laws that are fully uncompensated and the imposition that it puts on us, and
Well-
then decreases for patients who have true medical
In
need.
all honesty, they got to go someplace, right? They've
Yeah.
got to be looked at somewhere by somebody. And all our job, and I think that's fair, is to clear. But then you got to play the other side of that game and get them out. And
But
get 'em
looked
somewhere.
at, my point is that the 5150 essentially gives a right to be hospitalized for 3 days because you say you're going to hurt yourself.
Yeah.
You know, that is not medicine. That's a social construct that has nothing to do with us. And
Psychiatrist to determine if the patient is safe to leave or not. That's not our job.
I don't know about that.
Well, I agree with you that particularly nowadays legally it's the psychiatrist's responsibility. When you look at and we did a suicide chapter 2 years ago. I wrote it. I remember it very well. When it looked at whether there's anything special about the psychiatrist's skill set in predicting who was actually a danger to themselves or a danger to others, it turns out they're no better at it than anyone else.
Yeah,
but
exactly.
legally, they carry the responsibility, and I think most of us accept that.
What do you think it would take to get to something where if you show up at an ER 3 times complaining of suicidal ideation, the 4th time that you come, you're not allowed to stay?
Well, you write them a prescription for a small caliber handgun. Yeah, right, exactly.
I mean, it gets
Prove
this
it.
idea. Yeah, I mean, there is a certainly, you know, there are people who prove that they are never going to hurt themselves, and I feel very comfortable discharging them with their fake suicidality. Having said that, these are laws. I mean, this is in California state laws, 5150, and in many other states and bearing other numbers. And I don't know that you can't do anything. I mean, it is codified in law, and I think that it's a terrible imposition on us, and it puts what is a social problem of people that feel bad about their lives and directs them directly into a medical facility where they don't belong, and they suffer, and it's a non-therapeutic environment, and it hurts our other patients, and it's just terrible all the way around. And I think we should be a lot more outraged about that than we are, frankly.
Yes,
the only
suicide is looked at the wrong way. It is the sincerest form of self-criticism. And when you think about the fact that they wander in and out and in and out, and you look at the things we keep in an emergency department, defibrillators and all this kind of stuff, what is it that we have
Yeah, it's nothing.
that certain other segments don't have? What's happened is we've become America's garbage can. If your mama don't like you, if the police don't want you, if all of your friends are drunk and stupid and crazy and gone, come on down. We'll take care of you.
Now,
And that's what's happened.
I would just counter with one thing, that when you look at acute undifferentiated agitation, which a lot of these psych
I'm not
patients
talking
are,
about-
That's different.
acute undifferentiated agitation often really needs a medical workup, and in various studies, the number of them that have a serious medical problem ranges anywhere from 20 to 70%.
No.
Understand, we're not talking about acute undifferentiated agitation. We're talking about the person who otherwise looks well with great vital signs who says, I want to kill myself. Please be clear that the acute undifferentiated agitation is an entirely different world, and that needs a workup. And we actually have special things to offer
Frankly,
that,
it frustrates
tox
me when they
knowledge,
put them
etc.
on a 5150. It frustrates me when people put those kinds of patients on a 5150. Those people are not 5150. They are sick, often critically ill, maybe not by vital sign,
Right.
but they have big problems,
Right.
and they need a real medical evaluation. And labeling them 5150 does a disservice.
And I think, so it's clear to everybody in this room, having these psychiatric patients take up beds in the emergency department for days, maybe even a week at a time, is a problem. A big problem. But I mean, the point of this panel and the point of this session is to hear if any of you have come up with a solution,
Any
or
solutions?
it's something that you tried and failed, not like a failed solution.
So
I
we don't
guess.
have to redo that.
Has anybody, because I'm sure there's been some attempt by somebody out here, someone's group, to deal with this problem, and I think everybody would love to hear about what it was.
I work at a 60,000 patient year emergency room.
It's tiny.
We have problem space. So we built over the past year a psychiatric extension, which is a euphemism for the funny farm almost, because they're out of sight, out of mind. We're closed a multitude of psychiatric facilities, and we've had patients vegetate over there for a week.
It's locked. It's a locked service.
And when I go over there to make my rounds, they suddenly come out of their rooms where the stretchers are this far off the ground, and no pictures on the wall. There are no windows. They don't know what time of day it is. It's like back in the Darby Dix era. It's not the solution. Even though they're all been seen by behavioral health, they all need to be admitted, and they're also mixed in with the people that were drawing from alcohol.
Right.
And like you say, they go and
Right.
You've drawn a terribly frightening portrait of this. It sounds like Night of the Living Dead as you walk in. They're coming out of their rooms at
Sounds
you.
like-
Oh, my God.
Because they become isolated.
Right.
Yeah,
And then
it's
they're
very
out of
non-therapeutic.
sight, out of mind. They have a security guard and a nurse. The nurse is going over there because
Can't imagine.
And
All
what?
right, note taken.
Anybody?
Psych extension didn't work.
Go ahead.
But Greg, can I just say something to Greg? I mean, because you won't remember, but Greg was actually a neuro resident at Michigan when I was an attending in the ER.
Oh,
we wanna-
yes,
We
that's
want to hear
exactly
this. We want to hear this.
How long was his reflex hammer?
Yeah, the big reflex.
It's always been the repository for these people, right? I mean,
Yes.
that's never going to change. The ER is the place you go when you're down and out and nobody else wants you.
That's not what I wanted to hear. I'll buy a drink later.
Let me tell you one little story. In those days, there was not an emergency medicine residency program yet. So all the residents came down, and so that day you may have like an orthopedic resident. So you'd have to speak very slowly, right? And say, Gonzo. He'd go, And he'd say, come over here, Gonzo. And you would have to check every patient when they were getting out of there, because by God, those various residencies did not want to be taking care of a lot of these patients. It was very difficult.
What else
Yeah,
worked or didn't
comment.
work?
Well, we built what's called a behavioral health unit, which was the same thing. And the comments that what happens when that would fill up, then we'd start filling up our regular beds. And
But who was in charge of supervising that? Was still under like the mandate? Yeah. Right.
we can't, we saw a psychiatrist in New York. I saw for the first time, I can't remember how long, a psychiatrist. I had to write his prescription for him on the computer because he wasn't even in our computer.
Yeah, we had a psychiatrist get punched out yesterday, and I had to ask, was it a patient?
Psych things are like nature. They have more vacuum.
Yeah,
Build them more space, they fill the
They'll fill.
I agree. I think there's a huge unmet need or demand.
to work with them, think they have more time, and then all of a sudden our beds are filled again with psych patients.
Yeah. Agreed.
Comment.
Tried and failed up near Sacramento, where I used to work in Flannel County, where we had inpatient psych unit. People would come from everywhere, 5150, who clearly could have that 5150 eliminated, but the county would not allow the emergency physician to do that. And so basically, the patient had to be admitted because the psychiatrist would not come into the ED to evaluate these people. Yeah, just put them up in the unit.
Right. Those things have to be changed.
Did you like
those
the?
rules?
How
have
many
to
of you saw the
change.
Nevada story with their psych? So when they were discharging their people psych, they were buying them one-way bus tickets to a variety of cities out of state.
Yeah.
Did you see that? It's recently in the news. They're going after them. Yeah. Just do it quietly, because the fines, I think, are going to be large.
They're going to be big. As you think about it, what we've concluded so far is psych is a problem everywhere. Nobody has solved it. It is not going to go away. And, these are the bane of our existence. You realize a good day and a bad day in the ER are the type of patients. Chest pain, arrows through the chest, all this kind of stuff. Those are great days. We're happy.
Shoulder dislocate, I love them.
You get 3 or 4 of these people who are hanging out in the doorways, crying, this and that and other thing. Oh, my God, the shift never ends.
Well, they're there so
It's just
frequently, you
awful.
start thinking they're residents. Start
Yeah, they're
getting-
residents, right?
Yeah, I was just going to say, in Boston, we have a designated team, Boston Emergency Services team, that helps with
Best.
mental health placement.
Like it.
And in
Better
our
than PET.
department, we have a 24-hour cap, and if a psych patient has reached 24 hours, we actually admit them to medicine, and they go up on the floor,
Love it.
floor, and get them out of our emergency room.
There's a solution.
Well,
All I need
How
to
often
make
do you-
all I
how
need to
often
make
do you
that
hit
work
that?
is to make my clock go faster.
God.
How often do you hit
It
that
felt like
24
24 hours.
Oh, it's very rare that we have a psych patient admitted before 24 hours, but there's the occasional patients in there for 30, 32 hours, but most of the time at 24 hours they go up to the floors.
Even the 24 hours sounds too long, but even a 24-hour we cry uncle move to another service would work for me.
Oh, it's
Yeah.
great. It's great because we do need to spread this. I mean, it's clearly non-medical. It needs to be spread to the whole facility for the
Yeah.
facility
Shouldn't
to
be
react.
just our
yeah,
problem.
but make
Yeah.
sure that when you admit them to a floor above the 6th floor. Because that way when they jump out, it's not just an orthopedic problem. Okay, yeah.
There's a trifecta.
They'll be denied days. You're right. They won't. I mean, if you're using Interqual or something like that,
Yeah.
they'll be denied days.
Yep, yep.
So where I work, some people try to do the same thing.
Uh-huh.
They diagnose rhabdomyolysis with CK of 800
Yeah, yeah, yeah.
and needs them to medicine as well.
Right.
The problem then, when you come on shift, there are no medicine beds.
Right. Well, that,
Now you have 85-year-old with high sugar, chest pain, and you're dealing with scarlet lives.
Anyone who has some flesh missing, I'll just tell you that you can do better with this. You just got to hold that little piece of flesh, put it in a blender, then you can add it to the serum. That way you can get real rhabdo.
Yeah, yeah.
Get some real rhabdo numbers when you need them.
yeah, good question. There and then you.
I don't think it's a solution for you guys. Where I work, the nursing triage actually calls social worker right away when there's one of these cases, and the social worker sees the patient before the doctor sees it. So the phone is easier because they're allowed to call the psychiatrist, and it's kind of small community, so like if psych patient are known, everyone.
They're all known. Yeah.
So sometimes it's just like make an appointment for 3 days. So I see the patient, I see if there's something I can do right away, if there's a workup that I need to do, and then he has already his appointment, so it's like really easier. And actually the story.
And that social worker is available 24/7?
Yeah.
Yeah, I think so. So one of the things that I think we've heard that's come out is that the behavioral health unit, the extension, the creating of a new barn filled with crazies, that's not working. Social work seems to help. I'd say it made a difference. When we went to 24/7 social worker at our place, it helped. It doesn't help with all of them, but it certainly helps with some. And it helps with other things as well, sort of
Yeah,
the
as we pointed
homeless
out.
person who needs a wheelchair or things like. So it helps with not just the crazy, but with some of the other social things. So I think that's one of the things that if we're going to be boarding this many patients with psychosocial problems, I think you're in a good position to make the argument that 24/7 social work would be an advantage.
By the way, there are communities that are now starting to look at this flow of people coming in who are predictable every single day. Tom Mayer says it the best. I knew you were coming. I just didn't know your actual name, but I knew you'd be there. If you look at the zip codes of where the nursing homes send you cases, the best thing you can do, I promise, to cut down all of this stuff, go out to the nursing homes, make sure, the chief, that we have an understanding about what we're going to do with the various patients, the paperwork is filled out, so that you're not carrying on these stupid discussions at 2 in the morning like, is there a DNR, is there a this, there a that?
Right.
Because most of them shouldn't have been sent in at all.
So check for the PULST or the MOLST, depending on what state you is, physician order, life-sustaining treatment. And the other thing that you can do with your nursing homes that's very proactive is get a transfer agreement. Not that you're going to decide whether you're accepting their patients, but if they send them to you, make sure that you have some time, whether it's 2 hours or 3 hours, during which they won't lose their bed, no matter what time
Right.
of day it is. So that if you'd like to Super Bowl that puppy, boing, right back, you know, you have some accepted time frame on which to Super Bowl that baby back to them. Because it's a real bummer. As soon as they arrive, they're like, oh, no, we filled that with another patient, that bed. You got to have some sort of interval during which they don't lose their bed.
Yeah, you don't see this much in England, by the way. They rarely bring them from the nursing home in about to die. That happens here all the time. You know, you pull the sheet back, and all you can say is, "Oh my God, where do I start? I mean, where are we going to fix this?" The Brits don't do that. They quietly let them die and say, "Well, they had a great life. Thank you very much, and it's tea time now," and off we go. They do not take those patients who they know are about to die and send them in. I'll tell you that we need to go in that direction.
All right, I got a new one here. We're changing topics. This is, you got to admit, and you know how this goes, right? The nurse isn't available to take report. The nurse, they put you on hold. They can't give report. So you got this delay. And so there are a variety of solutions. This one talks about floor nurses must take telephone report within 30 minutes. Other ways that have been done is there's no report system. There's a fax.
Yep.
Just fax the report. There's no discussion. The other thing that happens is, you know, the bed is dirty We can't take the patient till it's cleaned, and somehow environmental services will take like 7 hours to get that done. So we actually had to develop at LA County a dirty bed policy. We don't use hallway beds unless the bed is dirty, so the nurse isn't going out of ratio. If they tell you the bed is dirty, we're like, fine, they'll be up there in the hallway. As soon as the bed's clean, you'll take care of it. So we actually developed a dirty bed policy. All of these are ways to prevent the nurses from doing this block thing. Because what happened before at our institution, and this person clearly encountered a similar thing, is if your nurses are on 8s, which ours were on the floor, what they would do is they don't want to take report an hour before the end of their shift.
Yeah.
They don't want to
call it
take
that.
report an hour at the beginning of their shift. So that means that you lose 2 hours per shift change. There's 3 just shift changes. That means 6 hours a day there's no report.
Then there's lunchtime.
And then
lunch break.
there's breaks. So that takes you up to 8 hours. So a third of the time you can't get a report done. And the floors, as you all know, are relatively insulated from the chaos. They have ratios and the beds have to be available. So you have to do things that break down that insulation. And these are a variety of things. One is rules about who can deny, about delaying taking report, faxing reports, dirty bed policies, things like that have all proven relatively useful. I think a fax and a dirty bed policy are really useful because the nurses will say, well, the bed's dirty. I can't, what do you want me to do? I don't clean the gurneys. I mean, it's an OSHA rule. The thing has to be cleaned. So then you make a dirty bed policy. That's fine. They'll be in the hallway till it's clean.
I love that when they say, well, the nurses are cleaning the bed. I have this vision of two
They are
nurses
nicking
licking it from end to end,
That's
weird
because you'd like to see them licking something else, and they're not. Trust me, they're not licking either.
Unfortunately, I now have that image also.
Yeah.
And I'll never be able to forget it.
Yeah, never.
It's going to require.
I've helped these young men. No, let me tell you what really happened is there was a study done by the Clockwork Emergency Department in Washington, and they looked at who did what with calling down discharges. And if you look at this hotel, very simple. They go in when they're done, the house staff in cleaning the room, they touch a number on the phone. That means that room, they can now release that to be filled by somebody else.
Someone paying.
Someone paying, exactly. Well, the problem up on the floor was they tell the desk secretary, and is she in any hurry to get that call down to admitting? Absolutely not. So what they did was they told the transporters, whenever you discharge a patient, you take them out, you touch these numbers, and if housekeeping hadn't retouched the numbers in an hour, the chief of staff of the hospital got called. All of a sudden, they cut 2.5 hours off that time, and when you think about it, that's a lot of time.
No, and so every time you do and we're going to talk about overcrowding, as I said earlier, but when you talk about overcrowding, and they do this stochastic analysis, which is like what causes a traffic jam, something I was experiencing this morning.
Yeah.
And they when they look at it, it's amazing that for example, if you have not enough beds in your hospital or the staffing's tight and hospitals want to keep their thing full, it turns out that changing the time of discharge in our hospital, when they did the stochastic analysis, changing the time, the most important thing you could do up front, there were multiple things you could do to affect overcrowding, but changing the average discharge time from 2 o'clock in the afternoon to 1 o'clock, even by each hour, from 2 to 1, very important difference. From 1 to noon, even a bigger difference. From noon to 11, an even bigger difference. And the reason is because you're changing length of stay. So decreasing length of stay by 3 hours is a 1/8 change in that person's length of stay. That means you have every eight times you do it, an additional bed in the hospital. And so length of stay so time of discharge is really critically important, and how soon that bed becomes available is part of that thing, because the bed's not available until it's cleaned, which is why you need a dirty bed policy.
Well, it seems to me that
every hour matters.
It seems to me that whether it's a dirty bed policy or a fax, or you leave the report on the phone or on a voicemail or something like that, or you type it in. I think what we're getting at here is we have to work with our hospitals to change the default position from us having to have permission to send a patient upstairs to the default position being when we're ready, they're going upstairs.
They're coming.
They're
Period.
coming.
Now, I'm not unreasonable. If a nurse just got 6 patients and the ward's going crazy, they should be able to call us back and say, we really, for extenuating circumstances.
Don't feed the bears. I'm unreasonable.
Well, I'm
they can
I'm
get
not, I'm
when,
not.
when we get
I-
6
I'm not.
patients, no one says, "Hey, we're going to take it easy
We're
on
all
you."
acting
Fuck
in
'em.
the interest of
When
all
they
the
get
patients.
6 patients,
It
they
may
can
not
take
be in
another.
their interest to be up
Do
there.
not feed the bears.
By the way,
I don't draw the lines so bright.
Yeah,
I don't.
Yeah. ER overcrowding is never ER overcrowding.
Of course.
It's hospital overcrowding. And when we approach it as a team, we're better off. One of the best things we ever did was got a retired doc, really smart guy. He became the bed czar. And he'd wander around at 6 o'clock at night and say, why is this person here? And when somebody said, oh, they're going home in the morning, he sent them to the unit we call the discharge. It's got a bunch of Barker loungers in it and TVs. The family somehow appeared and took them home. But why would we think at 6 o'clock at night it's not just as important to have a bed as it is at 8 o'clock in the morning? When you call admitting.
More important. I agree.
More important. Well, you call admitting and you say, I've got an admission. And they go, an admission? They're all shocked. What do we do here? We admit people. Why they're surprised at 6 o'clock at night that there's an admission, I have no idea. But you know what? When you got somebody who's asking other docs, a doc asking other docs, get your patient out. That's useful because you need somebody at that level to carry on the fight.
Well,
The
look,
second part of this one talks about the other part of this, which is there a problem reaching the doc who's going to do the admission? Is that what's hanging it up? There, you don't have orders for the ward. And so the second part of this person's note is get a good hospitalist group so that you don't have to play this game.
Yeah, right. But again, it's the same principle. The default is nothing delays the person going upstairs. There
Right.
may be a circumstance on occasion, but it can't be that we're asking permission continuously to send a patient upstairs. And
Bombs away.
And I think some of this idea of, why are they so surprised that there's an admission on a Saturday night, when they get a request every Saturday night for, in our hospital, 30 or something admissions. Why are they surprised as opposed to Monday morning? This is it's purely cultural and old, again, if an emergency doc asks for a bed, it's a surprise and an inconvenience. If a neurosurgeon asks for a bed, he says, I'm going to do a brain operation. This person's going to be in the hospital for 2 days. That's like they jump over backwards, they're bending over backwards to try to create that space. That's an actual emergency. A neurosurgeon wants to take out a brain tumor that's been there for 9 months. That's the emergency from the perspective of the hospital administration. Some of it has to do with finances. I
It took
understand
9
that.
months to make sure the wallet biopsy was
Right.
positive.
Some
Code
some
green.
of it is that, but most of it is just historic, right? The ED is in the bowels of the hospital. It smells like gasoline down there and all that kind of stuff. And they haven't.
You're lucky if it smells like
Right,
gasoline.
we have, right, vomit and gasoline, and we haven't been, and we're still working on trying to get people to recognize the truth, which is that the emergency department is the main portal of entry for the large majority of patients at almost every hospital in America now, and we need to be seen with the level of respect and dignity that the neurosurgeon who has 5 admissions, a month has at a minimum.
Except for elective surgery, we've watched in the country in the last 50 years go from 20% coming through the ER door to about 90% coming through the ER door because no pediatrician, no internist anymore wants to send them directly from their place into the hospital. Where do they go? They go to the ER. You know why? Because we're good at it. We're rapid at it. Here's another thing to stop. House staff coming down to work up a patient once they've been admitted, stop it. Because if they can't, they can do it up on the floor. But if they're down there for an hour, and then they've thought of 28 more laboratory tests, which the patient doesn't actually need, but they want to get. Now they're down there for another 3 hours. Just say this: you've got a patient, they need to get upstairs, right now. That's it.
My favorite is our acute care surgery says, well, we want repeat labs. Like we did a bunch of labs that we didn't need in the first place for you. We humored you. Now it's been 12 hours. They asked for repeat labs. My new line is to open up. We have on our tracking system, I can open up the adult waiting room. I open up the adult waiting room, which has anywhere from 60 to 90 people in it. I say, if all of those people say okay, I'll do repeat labs, but you got to get them all to sign off on it because they're all waiting for this bed. So after you ask all of them if it's okay to do repeat labs, we'll do them. But unless until then, I'm just admitting them.
And I don't know if it's on any of these orange sheets somewhere, but I'm just sort of generally curious to know if anywhere you guys are working, once a patient is admitted, either right when they're admitted or at a certain cut point in time, 4 to 6 hours, is there a situation where the admitting service takes over care of the patient, sort of in regards to what you were saying?
Even if they're in the ED.
Even if they're in the emergency department, so are there people just sort of by show of hands where that is the, and then how do you feel about it? Because I personally can see lots of pros and cons to that kind of thing. And I'm just sort of curious to know how you guys feel about that, the admitting team taking care of patients in what we have traditionally seen as sort of our real estate.
There's
our
only one
department.
reason I'm in favor of it, because it's filled my pockets with money doing the legal cases from the exact situation. Because when somebody else says it's not my problem, walking by them, this, that, and another thing, and the nurses get into that, I've got drawers full of those cases where the people upstairs should have done things, started procedures, treated the DKA differently. If you can avoid that kind of stuff, avoid it, only because when there's two masters, nobody knows what's going on.
Well,
They
I'd
just don't.
like to hear what people's opinions are. But what do you think? Especially those of you who sort of had a system where it wasn't like that and then converted or converted back. If you think it was better, because I sort of see maybe this medicine doc doesn't want to come down to the ED, so then they actually try to make a bed upstairs.
Right. So that's the argument is that it's pressure.
It's pressure, and I'm curious to know what people's real life opinion is like.
So you said
You're nodding your head. I'm going to call on you.
So we have
Australia.
admit is made, the inpatient team take over care. But if there's an acute problem, we'll still
Of course.
get and treat and ring them. But it stops us having to do all the crap, the ordering of tests, the writing of fluids, that the inpatient teams just haven't been bothered to do properly. And so if something like that needs doing, then our nursing manager will get on the phone to that doctor and say, you have to come down and sort it out. And they don't want to do that because that takes them forever because we're
There are-
not anywhere
yeah.
else in the hospital.
That's right.
And then we'll start to agitate to get the patient upstairs.
I mean, that's certainly the theory behind it, is that they don't want to keep having to come to you need to write this towel and I'll order, you forgot this, now I got to walk down 18 flights of stairs.
The
to come to
family wants
emergency
to talk to you.
department.
If they're rounding with their boss at the time, they're getting all these phone calls.
Right.
It's very powerful.
Anybody else want to share their experience of sort of admitting services, taking
So
care of patients?
all the admitted patients are covered at your place by the inpatient service? How
Right.
does it work?
I mean, it's nice on our end, but it is scary, and there's been times where the inpatient service comes down and all of a sudden they decide this patient's still in the ICU.
My problem with it in an academic center is the unsupervised intern, the low man on the admitting team, is sent down, who's writing orders which I'm seeing are wrong, and technically I'm the supervising attending for the care, but I have no direct authority. This intern who's responding to an attending who hasn't come down is now writing, for a liter normal saline bolus on my acute pulmonary edema admit, and I'm like, you might want to discuss that with your attending, or belay that order, that kind of thing. So I get nervous about that in an
Comment?
academic setting.
I think our issue come up with the nurses because then the nurses keep coming to us and they ask.
Right.
Yeah.
Yep.
So the good thing is that it kind of gets the patient up to the floor quicker, but then our nurses are kind of burdened with getting some of those orders started, and then we get the patient and the family or whoever coming up to you asking stuff, and then it gets a little confusing.
No, the family, and I mentioned that's the other thing. A lot of times the call back to the admitting services, hey, the family's here, they want to talk to you. Well, I already wrote the orders and saw them and everything. Yeah, but they want to talk to you. I'm not in charge of their care anymore. I told them, I'm not in charge of their care. Let me let you talk to their doctor. Are you the doctor? No.
Yeah, and I do recognize that these issues cause a lot of problems with the nursing staff who thinks you're being a jerk by not responding to their concern about the patient. You have to, these are the nurses you work with on a daily basis, unlike the medicine docs who don't work with them frequently. So they think you're being unreasonable, and so that is something to guard against for sure, because you certainly don't want this to poison your relationship with the valuable
comment?
staff.
Common.
Did anybody ever develop an admissions unit? I mean, one of the reasons that the nurses on the floors don't want to take a patient the last hour or two of their shift is because it takes them 45 minutes to do all the paperwork, to do the
Yep.
okay? So, has anybody, because I've tried to do it and I've been knocked down forever on this, an admissions unit where a patient that's admitted goes there, their dedicated nurses do all the paperwork, etc. As soon as the bed upstairs is ready,
Yep.
Yep.
So we had one at LA County for years. We sort of have one now. So we have an SOU, which is a surgical obs unit, but it's really a staging area where they sort out their admissions and make sure which team is covering and make sure that that all the last studies that they want that are available on the first floor are gotten done. They want some more plain films. Don't send them to the 9th floor away from the X-ray machine. Let's get that cleaned up. The problem with it is it just takes and I'm fine with it. It does work pretty well. The downside of it is it's just taking up real estate in your hospital that you would like to actually maybe be more inpatient beds.
But you're not going to get authorization, at least permission, certificate of need.
Right.
You're going to get permission to have more inpatient beds.
I gotcha. I gotcha. So it works. I mean, I'm not totally down on it. And we had it for many years in the old LA County. We had what was called the red blanket room, where you could send any medicine admit you wanted there. And it was so packed with gurneys back then that if a patient had to vomit, they had to vomit on another patient. But that wasn't really, it wasn't really dignified, but that's what it looked like.
By the way, the comment was made about the lowest level house officer. That's absolutely something, if you can avoid it, speak to the highest level person possible. Don't talk to the monkey. Talk to the organ grinder. Because to get things done, and I actually, there was a lecture at Michigan given by the guy who was chairman of surgery, who actually said, you really need us in the emergency department, because I can send them upstairs and have the third year take out the appendix. It's the decision making that happens. And when you have to go through 7 levels of decision making, the first year comes down. Who does he call? The third year. Now the third year calls the 5th year, who then eventually calls the attending. Oh my God.
Or the fellow. Don't forget the fellow.
There's a fellow. Come on.
Don't forget the fellow.
Oh, gee, how could I forget the fellow? Oh, God, it's painful. All right, next, another question. Sharp clinical nurse in triage. We're going to
Yes.
start a fight.
Yeah, I'm pro.
Triage. Okay. Able to
Oh, sorry.
pre-order essentially 100% of needed x-rays, labs. They usually have labs, the blood drawn, and 80% of work done before the doctor walks in the room. I don't know. Who wrote that one?
We also, I have a similar about advanced nursing protocols, et cetera.
Or mid-level at triage.
Yeah,
How many of the
couple.
mid-levels work in triage right now? So one. We torture our mid-levels with this at times. The problem is, one, sometimes stuff is ordered that you don't want, and then you have to address it.
Sometimes.
Yeah.
A lot of the time. Right.
Yeah, well, sometimes can vary. You can feedback. It depends how big your service is and things like that. And the other problem is that sometimes pretty expensive stuff is ordered.
That's right.
Scans. Our mid-levels are ordering scans. They often try and run it by someone, but often they run it by the ER doc who's not going to see the patient.
Yeah.
So now you're talking about spending lots and lots of money in a workup and creating data that you may or may not have wanted, which can be a problem.
Here's the one problem with this. When we look at this data with regard to consistency of workup in the emergency department, looking at various attendings, there could be a difference on this panel of 3 or 4 times as to who's getting a CT on a headache. I am a conservative on all issues. I get nothing. I've got people who get 5 times as many CT scans as I do. So now that poor person out at triage has to kind of find out who they're working with.
Yep.
Is that cheap-ass guy Henry out there? Okay, get nothing. And if that's that other guy, just make them glow in the dark, right? Just do a scan on everything. We haven't really put any controls on the quality of our health care that way, and we just kind of let anybody with a degree order anything they want. If you actually had to take that out of your pay, let's say they gave me X number of dollars for the whole thing, my salary, the workup, everything, you know what? You get a lot better at what you're going to order. You just would.
But I having noted all of these objections, how many people think that having someone who knows how to do the auto ankle rules, getting an ankle X-ray on you right up front matters? I think it does. For
Yeah,
a
but
lot
they
of
don't
simple,
follow the auto
for a
ankle
lot of
rules.
simple things,
No one follows
for
it.
God's sakes, get me my point of care
one
testing,
follows
get me that pregnancy test, a hemoglobin, and an Acute check done. So I'm not starting with that. If we start talking, so I think that for most people there is a practical part of this, which is really simple binary logic kind of stuff or compulsive stuff that's not expensive that you can do pretty quickly. And I think most of us recognize that if that stuff's done before you see them, it shortens the time that you're going to be waiting to make a decision about them. And that's why it's popular, even though there is this downside.
Right.
My experience with it at not at county, not at my main place, but when I've moonlit at outside places where they do it, is that as long as you just provide a little feedback and it's an open communication door to the person in triage, you know, if you've made it clear, you know, talk to me before you send tropes or BNPs on people or D-dimers. Talk to me a little bit before you do that. Then I find that you can shorten, then it becomes easy to match your ordering style to what they're doing up there, and it works okay. And obviously the people who are in that position, if they have to do it for any length of time, the variance will come down and start to match what you'd like. So.
I think triage, though, in the country has fallen apart. Triage was for one thing, to decide an order in which we're going to see patients. Now it's become this whole world unto itself in which we've been asked to do way more than we should. And now say, well, you don't have the official nursing exam yet on the chart. You don't have this or that. Quite frankly, if there's a bed open, get them to that bed. Let me get in there and get the thing going. There is nothing worse than having to go sequentially through all these steps on a problem that you can get right to and get it done.
At our hospital, we're working on implementing a split flow process to kind of eliminate that, because right now we have this issue where when they mention that whole triage, the nurse order, I wouldn't trust some of our nurses, and I was a nurse before I was a PA. I wouldn't trust some of our nurses to order half the things they would do, because they do, instead of triage and just get somebody into a room and let the provider carve it out. They're out there judging somebody who's like an allergic reaction, trying to determine if they really are short of breath or not.
So by split flow, high and low acuity, you're talking?
Well, just basically, what did you come in with? What's the complaint? And get you into a room and kind of, is it minor or major? So you come
by
in with
acuity.
an ankle complaint, it doesn't look like it's about to fall off. You can go into a minor room in the provider seat, and you have these higher acuity complaints that will go into a major room. That's going to be like an IV or
They're going to need a gurney.
Yeah,
So
Yeah,
basically divided gurney, no gurney.
I mean, my feeling is that generally speaking, like it or not, there is going to be some sort of a push to have a provider up at triage, and that's going to range from a mid-level provider to actually a physician. You know, the real question is what's going to be the scope of what they do and what is the goal of what they do, right? If it's to decide who needs an ankle x-ray or not, I'm all for it, because even if they get that wrong, I don't particularly care. But, you know, when it gets pushed to these things like patients with chest pain and headache, where, like Greg said, I mean, the practice variability amongst even the panel and the people in this room is so extreme. I think that when you give them just 2 or 3 minutes to kind of make those snap decisions, you're probably going to get a lot of unnecessary tests. So I think really it's a question of sort of where does it stop? You know, like what do you allow them to order and triage, those people who are working there, even if it's physicians? You know, and what do you say, like, you know, I get it, this could make the process a little bit faster, but really it could slow things down and hinder it with unnecessary tests, so we should just wait until they come back.
How many people have a physician in triage?
A docket triage.
Doc in triage? Just a couple.
Just
all right.
two.
Wow.
Go ahead, comment.
So part of the other issue is, I mean, I can sit in triage and write all these beautiful orders. Nothing is going to get implemented until that patient goes into a bed 2 hours later.
Well, that depends on where you're working.
That does
See,
depend.
our nurses will send them right to x-ray. They'll get there even before they get bedded. They'll get x-rays and things like that.
Me to order an ankle.
Right.
Okay.
Why do you say inevitably that's the way it's going to be when Gambles wrote a really great article on all these things? The only thing proved to be effective is bedside registration. And that actually was looked at what you're talking about. And it's cost inefficient. And the main thing what we need to do is get a doc to the patient as quickly as possible.
I agree.
Get them into a room. That's what you do.
I think it's because of all these
Wow.
different CMS, JCO, like quality indicators that say, okay, patient comes in with pneumonia, you have to get them seen in X number of hours. You have to get their antibiotics in with this. Someone's got to see them, and it's not going to be a nurse who's going to do that. And if you're working in a really busy place like ours, where the wait time can be 14, 16, 18 hours, you know, I don't think that if you're working in a smaller place where there's a quick wait time to see a doc, it's going to be much of an issue. But where we are, we have to come up with some way to meet some of these quality indicators. We have to. And it's difficult to think of a way outside of having some kind of provider up at triage making some command decisions, and some difficult ones.
I work at a small community hospital, and so getting a bed available is usually not as much as difficulty
Right.
in a water institution. But my friend who works at a bigger hospital down the road says, man, we've had
Absolutely.
They don't want to wait, and they're dying to track them down, try to get their phone number, call them, and say, X-ray showed something. I mean, it could be a nightmare on the other end, too. So
Yeah, this is why Greg said that this is not a one-size-fits-all. The solutions
right.
are very institution-specific. They might even be day-of-the-week specific in terms of what's going to work. And I agree with you. If you're getting X-rays or CAT scans, we have CAT scans on people who are LWATs.
Yeah.
So they got a CAT. So now you're looking at a CAT scan. You got no data on them. You can't. In our patient population, about a third of them don't even have a phone. You know, their address is 4th Street between the cardboard box and the fence. Try getting that one back. So you got problems.
By the way, if you look at this panel, you're the largest emergency department in the United States, I think, volume-wise, and you have, what, 70 residents or something like
We got
that?
68 residents, 131 bed ER, but the ultimate problem with the math is they built us a 600 bed hospital on top of a 131 bed ER. You could do the math. That's just, I mean, a 600 bed. How many of you are in a 600 bed hospital? There's probably a couple people here. That's a 50 bed ER or a 40 bed ER.
This is a pound of
131
shit
bed
in a
ER
half
should be
pound
a
bed.
1,000 bed hospital.
Yeah.
So they didn't build enough beds for us. It's obvious.
You know, the funny thing about the mid-level at triage, the NP or PA, I find it very interesting, particularly in our own shop, where I think that the hardest thing that we do as physicians is make the decisions on who's sick, who's not, who needs a workup, what is that initial workup. That's the main important medical piece of what we do. And when we turn that over to either a nurse via some advanced nursing protocol or to a mid-level, I feel like we're turning over sort of the most important key piece of being the physician. And in fact, I'd much rather have a physician at triage who has time to do that and then use nurses and physicians' assistants to track down the results of those things and then to cycle back on us and say, you know, everything was negative that you ordered, can that person go? I mean, I think we're all talking about trying to get patients seen quicker by the definitive provider, and whether that happens via bedside registration status or changing the point of the definitive provider earlier in their course, I think that's really valuable. And I don't like at all when 80% or 100% of the workup is done by the time I walk through the room. I think that devalues what I do, frankly. Yeah.
Now, you mentioned bedside registration, and usually that's up here, but it's become so universal that it's falling off these papers. How many of you have bedside registration now? So that movement has gone pretty far because it is one of the few things that's been proven. A lot of these processes of care are hard to prove outcomes, right? You can only measure the process because the patient outcome's not going to depend often on the process, right? So all you can do is measure times and things. And the only one that's been proven, because it's a hard thing to prove, I agree with you, is bedside registration is the one that's been gotten the most attention and most success.
If you want to spend so little time and make things flow better, let me ask a question to decide whether you're dysfunctional. How many of you have seen a patient, gone in to see a patient with low back pain in the last month who still had their shoes, socks, and pants on? Lift your hand up.
Come on.
Yeah. You know what? You're dysfunctional because if you really want to organize something to move, you want to get from point A to point B and get it done. My ophthalmologist, when I walk in there, somebody has done my pressure, somebody's done this and that, and I'm sitting at the slit lamp, and it's ready to go. Now, what is so hard about having patients properly prepared, instruments in the room, so when the provider, whether that's a PA or a doc, steps in the room, you can get the work done? See, it's always strange to me when you're wandering out, looking in drawers for things and trying to get things done. You know what?
Sore throat, the tongue blade? How could I possibly need a tongue blade?
How could you possibly need a tongue blade? And I think that this kind of thought, we are the only business in America which hasn't gone through a redesigned model to ask these kinds of questions. Get it done.
And it leads to embarrassing moments for the residents. Fever, unknown source, diabetic, shoes and socks on. I'm like, what's underneath those?
And they're setting, they're setting you up for failure.
Well, he can't feel his feet, and you take the shoes and socks off, and like half of the foot is like, black and dead
and green.
Like, I think we found the source.
Yeah. Why? That's the question.
That's a good question.
I'm in a brand new hospital that I moved to a few months ago, and I've talked to my colleagues. They've given up. The nurses know when I'm working, you better get them undressed.
When we built the new hospital at the University of Michigan, I said, what we should do is throw a party for everybody who worked in the old hospital, and then seal it up. Because the problem is, what we did is we brought those.
If you're not picking up on the theme of Greg wants to kill half of the population.
Yeah, half the population. But the problem is, if we
decrease crowding.
If we, yeah, exactly. If we bring the same attitudes from that era into the new environment, I don't think we've made the advances we need to make. It's a thinking process here that says the best thing for the patient is to get to the provider as soon as possible with what they need to do what's needed to be done. I don't know why we can't figure this out, and we shouldn't tolerate it anymore. It's just not right.
Well, and I do think that's the point of this session, right? As you said, the literature comes up with typically in medicine, thinks very narrowly, unlike the literature in, say, management sciences, which does tend to think, in terms of big organizational structures and stuff like that. And we have to start pulling from that and then testing those models out in our own environment. Whether it be scientifically or practically is another issue, but I think that's a great point, is we shouldn't be tolerating it, and that's what a lot of this meeting, and particularly this panel, is about.
Their hospital probably sees 25-30% that need admitting, something like. Is that a fair number?
I think we're like 22%.
Yeah, most of us work in places where it's 10 to 15%. That means most people go home, which means most people are horizontal. The vertical horizontal question goes on all the time. They actually walked in and were not good. And somebody here has mentioned the split flow process. Would you like to explain that to us, please?
I think
She did. High, low, and
she did. This transient global amnesia.
Okay. But we always think that you need mid-levels looking at the quote-unquote fast track. I think those are the most difficult patients there are. The simplest patient in the ER is the 55-year-old guy who's diaphoretic, ST segments up.
Hey.
You love those.
Be there 2 minutes.
They're 2 minutes.
GSW to the chest.
There's nothing I love more than a patient who I have to intubate.
Right.
Review of systems unavailable.
Yeah.
Critical care time, 32 minutes.
Yeah, exactly. And I think the toughest one is when grandma says, I don't feel good. By the way, I'm weak and dizzy since 1942. Those are tough cases, and yet we think those ought to be seen by the mid-levels as opposed to the docs.
Right.
And I think that's just because all of us hate those cases.
Yeah.
And so we've dumped them.
There's one here that I know everybody on this side of the panel kind of want to talk about, was the implementation of point-of-care testing in the emergency department. So this particular person is talking about all sorts of different tests, from VBG, INR, looking at pregnancy tests, troponins, rapid troponins that we can now get bedside. So we definitely, I think that probably most people have some form of point-of-care testing in the emergency department. Is that right? How do you guys feel about the way it impacts your flow? And I heard I like it. I heard it doesn't.
So it depends a lot on what your turnaround time for your lab is. If it's an hour, it's probably adequate for most things. The one that turns out to have the most impact is, because let's take a chest pain patient. You're getting a troponin, a chest X-ray, a bunch of stuff, an EKG. The idea that you need a bedside troponin for that patient is probably not true, because you got a bunch of stuff cooking. You want to see their response to pain and things like that. Now, if someone's going to ask you to get a second troponin for disposition, so you have a delta trope, that second one would be awful nice to have a bedside, because now that is the rate limiting step. So the first troponin isn't, but the second troponin is rate limiting in some cases. So it turns out to be pretty messy. There's a bunch of literature on this. I actually did a point-of-care testing thing for ASAP one year, and the response to that lecture was interesting. People are really entrenched in their camps, the ones who love them and think that it changes things dramatically, which may be very specific to their work environment, and the ones who think it hasn't made that big a difference. The bulk of the literature says it makes relatively small differences, smaller than you'd think, in terms of overall ED length of stay. And there are a bunch of headaches and costs with it in terms of certifying them and jumping through all of the point-of-care testing regulatory hoops that go with it. So it's not. If you thought it was a slam dunk, I can tell you from having looked across that literature, it's not a slam dunk. It's fairly institution and problem specific in terms of whether it has yield.
Yeah, and you could have pathologists who have, a bug up their nose about this. They wanted us for a while to send every stool guaiac down to the department. That's insanity. The other thing is, we can do the pregnancy test. It's very interesting that the pregnancy test, which we need on women of childbearing age.
One thing that we do need is
it's
the point of
one
care.
thing we need to get the rest of the care going. And I never ask, are you having sex? I don't care. I just want to know if you're pregnant. That's the only thing I want to know. And the test pretty much answers that. They wanted all of those sent down. And you know what? We could do them just fine in the department, and it slowed us down tremendously. The pathologists and the emergency docs do have different agendas occasionally. We should just recognize that. They want to be able to charge for the stuff.
Well, they have licensure issues as well.
Yeah,
I mean,
yeah,
there are things that they
CLIA.
worry about. Yeah, I mean, I think that this is well summarized, that the point of care testing is not by any means obvious that it reduces things. And then typically the point of care results are less accurate than the full lab version too. So if you're going to get inaccuracies and have to go to the full lab version anyway on a relatively frequent clip, then you're really just not.
We
you're
come off worst in
accepting
these
a lot.
discussions when we go to the meetings and they say, your own literature says you didn't need the test anyway. Why do you need to have a CBC or this, that, and another thing in the department when the real matter is most people don't need it and you over-order anyway? This will help decrease your over-ordering.
And
None
then
of
the
which
whole
is true.
story about why there's so much regulation is the CLIA story, right? Clinical laboratory, that whole regulation. You would think that all of these regulations on point of care testings came about because there was some massive screw up or inaccuracy that proved that the lowly clinicians were incapable of doing these bedside tests in a reliable fashion. That, in fact, is not the story. The story is that the pathologists themselves had terrible outcomes in a particular test, and that test was the Pap smear, where there was huge diversity in their reads, and it resulted in a big scandal, which led them to say, we need to tighten up quality control. So it was the pathologists telling on themselves for their own screw-up that led to the tightening of the control of all laboratories, and that's when they came down and snatched the microscope out of your emergency department, tried to steal your urine dipsticks, and suddenly there was a black market for guaiac developer in your hospital.
Right, exactly.
Was because the pathologists themselves screwed up. And then at Rick's Hospital, I actually had to take we have to do it for our residents now. We have to show that they're competent to do a guaiac. And initially what they did was they sent down a smear that was positive on one side and positive and negative on the other. But you had to turn it over to read it, so the A went to the other side. So at Rick Bucata's Hospital, I'm not making this up, too many of the clinicians got it wrong because they couldn't follow the A when they turned it over, so they misread it. So they actually said that certification process for guaiac was no good. I actually got a registered letter from the administration at Rick's Hospital saying my guaiacing status had been revoked. I got it right, mind you. I got it right, mind you. And then they had to redo it with color blindness testing, but not red-green because your guaiac developer turns blue, with blue-gray color blindness testing, and then they made us all do that, and then I was re-credentialed for the privilege, the high art and low science of guaiac.
Yeah.
Seems reasonable.
Understand, Billy tells the story a little differently, each time. The truth was, he actually thought it was a taste test. So, all right. Any issues anybody wants to hear here? Has everybody read the stuff?
I've got mine done.
Done.
Yeah, close enough.
All right. Well,
What do you want to hear? All right, listen.
pick
If
a
that's
winner?
the case,
we got to pick the
choose a
winner.
winner.
Pick a winner, right?
we got to pick a winner. Go ahead,
Boom.
throw it in there. Somebody get it.
Billy?
No, go that way.
Okay. There we go.
Got to be present to win.
Tim Galligan.
Gallagher.
Gallagher.
Gallagher. Oh, he's here. Okay.
He's
Bam.
here.
There you
Nailed
go.
All
it.
right, you win.
Winner.
Give that to Bob on
It's,
the outside so
Starburst.
that you can say that you were the winner.
All right. See you back in 15 minutes.